Hello, this is Anthony Zeitman, the Red Journal's editor, and I'm making this podcast on March the 23rd, 2020. For those of us in Boston, this is the first week that the coronavirus pandemic hit home. For many of you, it's been a fact of life for weeks or even months. All of us have had to come to terms with major disruption as we attempt to keep our staff healthy while at the same time continuing to treat our cancer patients. This week, the Astro Journals received many papers from around the world on many aspects of this crisis. Some have reported local strategies taken to mitigate the risks to staff while remaining open for business. Several have looked at ways to clean and extend the use of personal protective equipment, while others have looked at specific disease sites like breast or prostate and worked out whose treatment should be deferred and whose shouldn't, and who might be safely hypofractionated and who not. All of these papers have been channeled to our sister journal, Advances in Radiation Oncology, whose editor, Robert Miller, is managing them with rapid review and immediate publication to ensure that this information is swiftly shared. You can find them either on the Advances website or at astro.org. It's difficult to have calm and equanimity in a time of such uncertainty, but life does go on, although very much altered. Research is still happening, though its pace will temporarily decline, and the Red Journal, as it has done for nearly 50 years, continues to publish. There's plenty in the May edition that's worth highlighting for listeners. One of the great clinician philosophers of radiation oncology, Dr. Eli Gladstein, died recently, and in this edition he's fondly remembered in a tribute by Dr. Norman Coleman, the head of the radiation oncology branch of the NCI. Eli, as he was known to everyone, was forged in the furnace of Stanford University in the 1960s and 1970s, at a time when incredible strides were made in the treatment of the lymphomas. He was a master clinician, a legendary teacher, and a great advocate for our specialty. He was never afraid to either sing its praises or to call out its excesses. Raised in Iowa, he had an earthy sense of humour that often came through in the titles of his many excoriating Red Journal editorials. Among them, my favourites are Seduced by Oxygen, a reference to the disappointing path taken to seek out hypoxic radiosensitizers. There was the Omega on alpha and beta. This was about how we naively chose to overfit radiation to a simple fractionation model. And there was Beware the Medical Industrial Complex and Alice and Academic Oncologists Meet in Corporate Wonderland, warnings about the dangers of corporate influence on research. And finally, my favourite, The Return of the Snake Oil Salesman. Well, I'll leave you to read that one yourselves if you want to know what that was all about. Eli was the conscience of our specialty and someone who has left a huge void with his passing. He really will be sorely missed. And now to some clinical science. And let's begin with hepatocellular carcinoma. SBRT and other ablative therapies have an emerging role in the treatment of this disease, alongside resection and transplantation. Durand de la Brunière and colleagues from the Institut Gustave Roussy in Paris looked at SBRT in patients with solitary 1 to 6 centimetre tumours who were inoperable either by virtue of their medical condition or by the tumour's location. They gave the kind of radiation doses that still make me wince, 45 Gray in just 3 fractions, and they report remarkably good local control at 18 months of over 90%. Grade 3 or higher complications weren't trivial, they ran at 31%. These authors argue that their local control and overall survival results appeared good despite the patients being unfit for transplantation, resection, ablation or embolization treatments, and I have to agree with them. A second paper on HCC comes from Seoul, South Korea, where they see substantially more of this disease than we do in the West. The outcomes for patients with advanced disease are very poor, and so this group aimed to improve them by combining the standard of care systemic agent sorafenib in a single-arm phase 2 trial with liver-directed concurrent chemoradiotherapy. In their protocol, 60 Gray was given by 3D or IMRT using standard fractionation, and it was combined with hepatic arterial infusion of 5-FU and leucovorin. Once all that was complete, patients were then started on sorafenib treatment. Among the 47 enrolled patients, objective response rates 4 weeks after chemoradiation and during sorafenib maintenance were around 50%. 19% were actually able to undergo curative resection or transplantation after this downstaging. The median overall survival was 25 months for the entire cohort, and the authors conclude that these were better than anticipated outcomes for this advanced stage of hepatocellular carcinoma. And I think that's true, but it's clear that the prognosis remains grim, and we still have a long way to go with this disease. We will finish this month with a new technique to salvage intraprostatic radiation failures. As you know, local failure after external radiation for prostate cancer is all too common, and a bit of a management nightmare. It seems excessive to start a man on hormonal therapy for the rest of his life for local disease, but equally, most of the salvage strategies, either surgical or radiotherapeutic, carry unacceptable risks. So what to do? A group from Utrecht in the Netherlands have chosen to carefully identify and map the margins of the local recurrence with MRI and choline or PSMA PET scans. They then perform single-dose HDR, 19 Gray, to the radiographically identified lesion. And they do this using truss MR fusion guidance. This they call ultrafocal MR truss fusion brachytherapy. After a relatively short medium follow-up of only 2.5 years, they report only 50% of these patients still remain biochemically controlled, and that's a number that's sure to get smaller with the passage of more time. It's of note that the majority of the local failures prove to be in-field, implying either that the single dose of radiation was not high enough, or that the margins were too tight. On the plus side, 90% had still managed to avoid androgen deprivation therapy so far, and the impact on patient-reported quality of life seemed relatively small. Well, I'm not sure how much this study actually moves us forward, but it does highlight the efforts that radiation oncologists are making to develop patient-friendly salvage options, and thus atone for the failures of external radiation. Well, that is enough from me for this month. I do hope that by the time we talk again in June, the tide of the COVID pandemic will have turned, and that our hospitals will be coming back towards normal, and that we'll all be out and about again enjoying one another's company. Until then, keep listening to the podcasts. No better way to pass the time.